Thank you for having me. So again, my name is Caitlin O'Neill. For those of you that don't know me, I'm one of the hematologists here at USC, and my primary focus is in non-malignant hematology. I see patients over here at Norris, and then I rotate on the consult services at both Keck and LA General. So today I'm going to be discussing keys to interpreting the CBC. So the CBC can really provide a lot of good information when it comes not only to evaluating for primary hematologic disorders, but it can also be reflective of other underlying conditions that may present with CBC abnormalities as the first sign of disease. So hopefully with this talk, I can provide you with some guidance for the initial investigation of some of the more common CBC abnormalities and indications as far as when hematology referral is most appropriate. Oh. Okay, and I have no disclosures. So here's an overview of the topics we'll be covering today. So I'm going to focus on, we're going to review the components of the CBC, and then I'm going to focus mainly on the differential and the initial workup for some of these CBC abnormalities. Based on my experience, most of the hematology referrals for CBC abnormalities are sent during that diagnostic phase, so I thought that would be the most helpful. And then at the end, I am going to briefly bring up this top concept of clonal hematopoiesis. So it's a very hot topic in hematology right now, and I'm not sure how much of that research is disseminated into the primary care field. But not only can it present with CBC abnormalities, but it can predispose to various chronic medical conditions that are typically managed in the primary care setting. So just an introduction to that topic. Okay, so why is analysis of the CBC so important? So the CBC is the most frequently ordered lab test in most hospitals. So there was a study done looking at the most frequently ordered tests across the inpatient and outpatient setting in various countries and of various income levels. And in all of those hospitals, the most common test was the CBC. And as many as 20% can be reported as abnormal. So at Mayo, they reported doing 1,800 CBCs a day, and as many as 10 to 20% of those were abnormal. So again, because of the significant number, not all of these patients can be seen by hematology. So it's important for them to undergo an initial workup with usually their primary care physician. So the majority of hematology referrals are also for assessment of abnormalities on the CBC. So this figure is taken from an abstract that was presented at the American Society of Hematology meeting last year, looking at hem-onc referrals at the Mays Cancer Center, which is part of the UT Health System in San Antonio. So similar, it's an NCI designated cancer center similar to Norris. So the objective for them was to get a global assessment of outpatient referrals in order to strategize about how to deal with the workforce shortage we're having currently in classical hematology. So as part of that, they looked at all of the referring diagnoses. So you can see here, 35% of all referrals were for classical hematology problems. And along the right, you can see a list of these referring diagnoses. So after thrombosis, anemia was the most common reason for referral. And as you can see highlighted here, most of the other referring diagnoses were for some sort of CBC abnormality. So it really accounted for about half of all of the classical hematology referrals. So a similar distribution was seen in this study. So this was done, this was an evaluation of outpatient hematology referrals at the VA Connecticut healthcare system after they implemented a hematology e-consult system. So over 85% of the referrals came from primary care clinicians. Again, the most common reason for referral was anemia. And in most cases, the etiology of the anemia was from a benign disease. But again, as you can see here, almost half of the consult were for CBC abnormalities. So lastly, as I mentioned, the impetus for that previous study I discussed was this shortage that we're facing of classical hematologists. So the American Society of Hematology has been conducting this longitudinal study over the last few years to figure out what factors are contributing to this shortage. It seems to be a combination of things such as a decrease in focus on non-malignant hematology in the training years and even in fellowship, hem-onc fellowship programs, and other perceptions as far as lifestyle, job opportunities, those types of things. But in the meantime, they are trying to implement certain programs to increase recruitment, but it is affecting the wait time for patients to be seen by a hematologist when referred by their PCP. So again, why it's important to potentially initiate the workup in the primary care setting. So next, I just want to review the components of the CBC. Again, I'm sure you order these almost every day, but just to make sure everyone's familiar with the various components. So this is generally the components that you'll get in every CBC. So we'll start with looking at the white blood cell count. So here it also shows you the typical normal ranges, although they will vary based on the lab. Again, you have to, at least here, you have to specifically order a CBC with a differential to also see the distribution of the white cell subset. So even if you're not ordering a CBC with a differential initially, if the white blood cell count is abnormal, you should repeat it to be able to get the differential information, because that'll be important in determining what your next steps in workup will be. So here you can see the 5 main subsets of white blood cells. So you have the granulocytes, which are the neutrophils, the eosinophils and the basophils, as well as the lymphocytes and the monocytes. So in a norm, and you can see it's in order of predominance. So in a normal differential, neutrophils should be the predominant cells, followed by lymphocytes, and then the rest of the cells will make up a small proportion. Now, sometimes reported in the white blood cell differential will be other immature granulocytic cells. So we do actually get several consults when these cells show up on the differential. I just saw one yesterday for someone who had intermittent appearance of myelocytes and metamyelocytes. So only mature cells should really be circulating in the peripheral blood. So really only the neutrophil. So here you can see the stages of maturation of granulocytes. So starting with the most immature, the myeloblast, up through the most mature being the neutrophil. If present, they will be reported as part of the differential. I would say the most common immature forms that will be reported would be bands, followed by the myelocytes and the metamyelocytes. Blasts really should not be present in the circulation outside of a setting like leukemia. And in that case, it's usually flagged by the lab tech and reviewed by the hematopathologist. So there's 2 main reasons why you might see these immature blood cells out in the circulation. So one would be that the bone marrow is being infiltrated, and these immature cells are being displaced before they can reach maturity. So the main things that we consider causing infiltrative bone marrow disease would be cancer. So that can be either a primary hematologic cancer, so leukemia, lymphoma, or a solid tumor that has metastasized to the bone. The second situation where we might see these early cells in the periphery would be in the case of bone marrow stress. So in the setting of infection, growth factor administration. So after getting GCSF, for example, we can see an increase in these cells, or even bone marrow recovery after someone's received chemo, or if they've had a toxic insult from another medication. These are another set of cells that aren't typically reported on the CBC, but might be present and flagged on your CBC. So these are atypical lymphocytes. So we say atypical because they have more abundant cytoplasm than the usual mature lymphocytes we see in circulation. So these represent activated lymphocytes, so usually CD8 T cells. We'll most frequently see these in the setting of infection, and it's typically viral infections, so things like EBV and CMV. Okay, so moving on to the elements that describe, that we use to determine if someone's anemic or what their oxygen carry capacity in the blood. So that's the red blood cell count, the hemoglobin, and the hematocrit. These really should be proportional to one another and can be used interchangeably, but we really use hemoglobin most commonly. as an indicator of anemia or erythrocytosis. So generally for most of the ranges, as you can see here for the other elements of the CBC, they should be similar between males and females. But as far as the hemoglobin and hematocrit, they are going to have a higher normal range in men, just because the androgen stimulation effect on the bone marrow leads to a higher hemoglobin level. The other thing that we're given on the CBC is several red cell indices, which we'll go over and are going to be important, particularly when we're evaluating for causes of anemia. So again, just a brief review of these. So your MCV is going to be a description of the cell size. So again, normal should be between 80 and 100. And just to remember that the MCV really represents an average size of all of the cells. So it is possible that there's a group of small cells and a group of larger cells. So wouldn't all really be normocytic. So the indice that gives us information about that variation in size is going to be the RDW. So generally, the RDW should be around 12 to 13%, indicating most of the cells are of similar size. Generally, as erythropoiesis becomes more disordered, the RDW increases. Then we have the MCH and the MCHC, which really both measure hemoglobin content within the red blood cells. So any disorder where there's a dysfunction in hemoglobin synthesis, you can expect a decrease in MCH and often a decrease in the MCHC as well. So just as with the immature granulocytes, where we can sometimes see them in the periphery, the same is true with red cell precursors. So again, we really should only be seeing mature red blood cells out in circulation. Reticulocytes will also be out in circulation, but they can be hard to differentiate from mature cells. The rest of the maturation should take place in the bone marrow. So again, similar reasons why you might see these immature cells are the same as for the immature granulocytes. So again, infiltration of the bone marrow, pushing out these early cells, or stress. So the most common form of stress causing red cell precursors to be in the peripheral blood would be hemolysis, where the bone marrow is really trying to pump out new, younger red blood cells to replace those that are being lost. And again, the most common ones that will be reported are generally the nucleated red blood cells, and they'll actually report that within the white cell count differential. Okay, and then lastly, we have our platelet count. So it's not listed here, but typically they also include the MPV, or the mean platelet volume. The normal range, again, is around 7 to 12. So the MPV can be helpful because it can signify whether there's a lot of early or younger platelets where you would have a larger MPV since these younger cells are bigger. This can indicate more of a consumptive process, so things like DIC or immune-mediated thrombocytopenia. We can also see the largest MPVs in certain inherited megaplatelet disorders. And then there's also some inherited disorders that are associated with particularly small platelets. So again, some additional information we can gain from the MPV when coming up with our differential. So although the reticulocyte count is not part of the CBC, it's an extremely important test that really we don't use enough. So it's the best indicator of how the bone marrow is functioning, which is important for workup of most of the causes of CBC abnormalities. So again, reticulocytes are immature red cells, and typically they're measured as a % of the total red blood cells. So again, a red cell lasts about 120 days. And in the setting of a normal hemoglobin, about 1% of those cells are going to be replaced every day. So a normal reticulocyte percentage should be 1 to 2% when the hemoglobin is normal. In the setting of anemia, we would expect that if the bone marrow is functioning, it should increase that daily production in order to keep the hemoglobin within a normal range. So that's where the corrected reticulocyte count is helpful. So that you know whether this is a problem with production or really a problem with increased clearance. So again, as I mentioned, this test is really underutilized in the workup of both anemia and pancytopenia. So this table was actually taken from a study that they did looking at how primary care physicians approach patients with suspected heme malignancies. But the first part of the study, they actually just looked at how they approach evaluation of anemia, since heme malignancies can often present initially with anemia. So here you see the tests that were ordered as part of the initial workup. So as you can see, only 66% of physicians ordered a reticulocyte count as part of the initial workup. Whereas to me, the one that sticks out that seems to be higher than I expected would be B12 and folate levels. Again, I typically will only order those depending on the MCV, which we'll talk about when we go through the algorithm for working up anemia. But again, I would just encourage everyone that the reticulocyte count should really be ordered in every workup for anemia. Again, because it's important in really making sure your workup is, if nothing else, efficient. Okay, so next we're going to start going through some of the differentials for the more common CBC abnormalities. So from those studies I presented, you could see anemia is one of the most common. So we'll spend a little more time on that. So there's a few ways that you can approach anemia. So one is using the morphologic approach, where you start by looking at the MCV, and another is the kinetic approach, where you're looking at the reticulocyte count and deciding if this is a hypo or a hyperproliferative anemia. This algorithm really uses a combination of the two. So we'll start by applying the morphologic approach, so looking at the MCV, and first we'll focus on the causes of microcytic anemia. So microcytic anemia, so those are going to be the anemias where the MCV is less than 80. So the commonality among these is that they're all due to impaired synthesis of hemoglobin. So because of that, typically on the CBC, we'll see a low MCH, and they usually present with normal to high RDWs. They're hypoproliferative, again, because there's a defect in heme synthesis, so the reticulocyte count is low. One abnormality that I think a lot of times is an easy clue to us that the diagnosis is thalassemia is that, unlike in other situations where the red cell count and the hemoglobin should be proportional, in thalassemia, they actually have an increased red cell count. So if you see an increased RBC in the setting of a microcytic anemia or even just microcytosis, that would be a clue for thalassemia. As far as other CBC findings, you could potentially see thrombocytosis in the setting of iron deficiency anemia. It's just a reaction to the underlying iron deficiency, or potentially with anemia of chronic disease, depending on the degree of inflammation. So I don't expect that you guys have a lot of time to be reviewing blood smears. I know that's primarily our job. However, I will say the lab techs often do report a lot of specific abnormalities when they manually look at the smear. And oftentimes that can be an impetus for people sending referrals. So it does seem like people are looking at these descriptions. It is very helpful because there are specific cell types that are going to indicate one disease over another. So this is a slide showing examples of target cells. So they have that bullseye appearance, which is really amongst the differential for microcytic anemias is specific to thalassemia. So you're not going to see target cells with iron deficiency or anemia of chronic inflammation. Another one that can be a little more specific is basophilic stippling. This is something we can typically see in sideroblastic anemia. And then it's not listed here, but lead poisoning is another cause of microcytic anemia, which can also present with basophilic stippling. So again, you don't necessarily have to be the one reviewing the smear, but they do report these abnormalities on the manual slide. And again, I don't know how frequently anyone is speaking with a hematopathologist if they're ever concerned about any of these findings on a smear. So really, as far as the workup for these microcytic anemias, you can start with the hemoglobinopathy evaluation just to rule out thalassemia. And then it's really going to be the iron panel and ferritin that are going to help you distinguish between the other three. So iron deficiency, again, you're going to have a decrease in iron stores, so you'll have a low ferritin, whereas the ferritin will be high in anemia of chronic disease or sideroblastic anemia. And then the way to differentiate between those two, so with anemia of chronic inflammation, if you recall, all the iron is being locked away in the macrophages, which decreases the serum iron as well as the iron saturation. But with sideroblastic anemia, it has more of a picture that's consistent with iron overload, where you actually have an elevation in the serum iron as well as the iron saturation. And I forgot to mention, feel free to interrupt me at any point with any questions, or let me know if anyone puts a question in the chat. Okay, so for normocytic and macrocytic anemias, we next incorporate that kinetic approach. So using the reticulocyte count to determine our differential diagnosis. So starting with the causes of macrocytic anemia, so again, when the MCV is greater than 100, most of these causes are related to problems with DNA synthesis. So the primary ones that are easy to screen for would be B12 and folate deficiency. I also included copper deficiency on here, and I think these are particularly important because I have noticed now we're getting a lot of referrals of patients who've undergone gastric bypass surgery, have various nutritional deficiencies. So something that's important to screen for. As far as, and again, typically the reticulocyte count will be low, the issue will be a production problem. And because it's an issue with DNA synthesis, it won't necessarily only affect the hemoglobin. These patients can also present with additional cytopenias. This is also true with things like MDS or people who are receiving chemotherapy. Again, a problem with DNA synthesis or maturation of normal blood cells leads to this macrocytosis and again, additional cytopenias. I would say macrocytosis with a high reticulocyte count is fairly uncommon. A few of the situations where we might see this is one in the setting of hemolysis. So the primary reason why you see macrocytosis is the increase in reticulocytes, which are larger cells, can increase the overall MCV. And that's true for hemolysis as well as bleeding. So it's really just due to reticulocytosis. And same with people who have folate or B12 deficiency who've been treated. Now their bone marrow is recovering and they're starting to increase their production of reticulocytes. As far as the workup, so again, if we're evaluating for hemolysis, our standard labs that are going to indicate a hemolytic process are going to be our haptoglobin, which will be low in the setting of hemolysis, fractionated bilirubin, so we typically see an indirect hyperbilirubinemia, and then LDH, which will be elevated again in the setting of hemolysis. These vitamin deficiencies are easy enough to screen for. So again, getting your B12, folate, and copper, and then also adding on the MMA and homocysteine, which are going to help you differentiate B12 and folate. So they should both be elevated in B12 deficiency, whereas the MMA will be normal in folate deficiency. And then if there's any suspicion for underlying liver disease, an abdominal ultrasound can be done. And again, the reason for the macrocytosis in liver disease is there's abnormal production of the lipids that are involved in making up the red cell membrane. And that leads to these larger red blood cells. Another potential etiology of a macrocytic anemia with a high reticulocyte count is cold agglutinin disease. So I just included, again, a slide that they'll sometimes comment on when the lab tech reviews the smear. If there's agglutination present, that can falsely elevate the MCV, which can be a clue towards cold agglutinin disease, which is a specific type of hemolytic anemia. Okay, and then finally, we're moving on to the causes of normocytic anemia. So again, we're going to be applying the kinetic approach before determining what is going to be on our differential. So something we commonly see is normocytic anemia with a low reticulocyte count, so hyperproliferative anemia. I would say one of the most common causes is anemia of chronic disease. So remember, we did talk about this under the cause of microcytic anemia. So initially, anemia of chronic inflammation will be normocytic, and the longer the process goes on, the more microcytic the red cells will become. Another common etiology will be a normocytic anemia from renal disease. So patients with worsening renal function will have a decrease in erythropoietin and will lead to a decreased production of red blood cells. The one other thing I wanted to mention that we often see as well is patients with diabetes presenting with hypoproliferative anemias. So they've actually shown that patients with diabetes have a blunted EPO response to anemia. So their EPO is inappropriately low for the degree of anemia. So ascending, and this can even be before they've developed any kind of underlying renal dysfunction that you might see on the creatinine or on your UA. So I think one graph that can be helpful, which I think they actually might include it now in the results of the EPO test. It gives you an idea of what the EPO level should be for the hematocrit level. So again, you can see if the hematocrit is normal around 40%, you would expect the EPO to be somewhere in, again, this is around the normal range, 6 to 10 or 6 to 12. But as the hematocrit goes down, you would expect this exponential increase in the EPO level. So again, can be helpful in the workup. We talked about sideroblastic anemia, again, can be normocytic or microcytic. As far as other processes that are more result of global bone marrow failure, so aplastic anemia is one. Typically, we won't see anemia alone. You'll also see other cytopenias, as well as with bone marrow infiltration. So like I mentioned before, when we were talking about those immature cells in the circulation, that would be a key finding that might make you suspect a bone marrow infiltrative process as a cause of normocytic anemia. And again, cancer infection, the main infections that we see with in this setting is fungal infections, as well as tuberculosis. And then fibrosis can also do something similar. Now, as far as normocytic anemia with a high reticulocyte count, once you've ruled out bleeding, which is really going to be dependent on your history and your physical, the only other etiology is going to be hemolysis. So I would say that for most causes of hemolysis, I think it would warrant referral to hematology. So I'm not going to go too in-depth into all of these, but I'm just going to briefly review some of the main groups of hemolytic disorders that we think about. And again, you'll evaluate for this initially by doing the hemolysis labs I mentioned on the previous slide. So we have factors that are intrinsic to the red cell, as well as those that are outside of the red cell, both of which can cause anemia. So some of the intrinsic factors that you might more commonly see, so hereditary spherocytosis is one. So this is a problem with the membrane and the structural proteins in the membrane. Hemoglobinopathy, so in those situations, such as with sickle cell disease or thalassemia, the problem is with making hemoglobin. And then you can also have problems with the enzymes within the red cells. So the most common enzyme defect being G6PD deficiency, which we can see precipitated in the setting of sepsis, infection, or with exposure to specific drugs. As far as hemolysis, where the red blood cell itself is normal, but it's external factors leading to hemolysis, we initially can think of immune-mediated processes. So this can be either autoimmune, where we think of warm autoimmune hemolytic anemia. So maybe you would consider in someone with other autoimmune diseases, such as lupus. But it can also be in the setting of alloantibodies. So particularly in someone that has just received a blood transfusion. So this would signify a delayed hemolytic transfusion reaction. Again, the best way to assess for antibody-mediated hemolysis is to do a direct Coombs test. which will be able to identify any of those antibodies bound to the red blood cell. As far as physical or mechanical destruction, so again, another factor that's external to the red blood cells. I think one important finding on the CBC that will indicate a specific differential is whether there's also presence of thrombocytopenia. So indicating a TMA or a thrombotic microangiopathy. So I would say we find these less commonly in the outpatient setting, unless it's for a patient who's getting their regular labs and there's an unexpected flag and they're sent to the ER. But generally, we do see these more in the inpatient setting. And these are typically what we would consider to be heme emergencies. So again, TMAs, you can also have immune-mediated causes of both anemia and thrombocytopenia. So we call this Evans syndrome. Again, just a combination of warm autoimmune hemolytic anemia and ITP. I think some of the other mechanical factors that would be important to recognize in the primary care setting that we do see once in a while is issues with heart valves. So specifically in the setting of paravalvular leaks, this can lead to mechanical destruction of the red blood cells. Typically doesn't also present with thrombocytopenia. And then things like vasculitis or even malignant hypertension can also cause mechanical destruction of the red blood cells and lead to this isolated hemolytic anemia. And then more rarely infection. So typically due to the parasites such as malaria entering the red blood cell and decreasing the red cell survival. But again, usually we find this by reviewing the peripheral smear. Okay, so again, I don't expect you to be able to necessarily recognize these findings on a blood smear, but I will say a blood smear is extremely important when we're trying to differentiate these types of hemolytic anemias. But they will often describe these findings on the lab tech slide review, because we'll get called because they've noticed schistocytes or red cell fragments, for example, on the slide. So again, this is an example of what these schistocytes look like. Typically, looking at the CBC, you might suspect this if you see a very high RDW. And again, in the setting of thrombocytopenia as well as anemia. Or a mechanical valve leak, as I mentioned, can also present with these fragments as well as malignant hypertension. Spherocytes might also be noted on the slide, and again, are really specific for only a few types of disorders. So really for hereditary spherocytosis, and then for immune-mediated hemolysis. So again, this can be autoimmune or alloimmune after a transfusion reaction. Bite cells, typically we see these with G6PD deficiency, or just can be related to specific oxidant drugs. I've had a few patients on dapsone after transplant where they've presented with this hemolytic anemia, which resolves after stopping the medication. And then some other findings that are usually commented on slide review. So sickled cells. So again, here in this picture, these more rhomboid shaped cells. And then Howell-Jolly bodies, so these inclusions in the red cells. These are Howell-Jolly bodies are often reported on the slide review if they're there. Even though we commonly see them in sickle cell disease, they can actually also be an important indicator of asplenia. So it can be a subtle finding that we can pick up in certain infiltrative disorders that are affecting the spleen. So again, things like diffuse fungal infections, amyloidosis, and definitely in patients who've had their spleen surgically removed. So again, a subtle finding, but it can definitely be helpful in some of these more difficult cases where you're not sure what's going on. Okay, any questions on anemia before I move on? Okay, so the next very common, I would say common referral we get is for evaluation of patients with an elevated hemoglobin, so erythrocytosis. So we really don't have a great guidance as far as what we should really consider as being pathologically elevated hemoglobin outside of polycythemia vera. So we really just use the diagnostic criteria to determine whether someone has erythrocytosis and necessitates a workup. So again, in men, it's when they present with a hemoglobin over 16.5, and in women with a hemoglobin over 16. Just like the reticulocyte count is our first step in evaluating anemia, the EPO level should be the first step in evaluating erythrocytosis, because again, it's important in determining our next steps in workup. So I think the first question you would probably ask yourselves is this a hematologic cancer? What factors would make me consider this? So the main consideration is really for polycythemia vera, which is a type of myeloproliferative disorder where the body is making too many mature blood cells. We really don't see erythrocytosis in the setting of other heme malignancies. These patients are going to have subnormal EPO levels, again, because this is being driven by a process that's independent of regulation by EPO. It can also be accompanied by elevated white blood cell counts or platelet counts. And then as far as the smear, again, what they might report on the slide review is these immature cells. So immature granulocytes, nucleated red blood cells, or teardrops on the smear. Which are usually indicative of fibrosis in the bone marrow, which can occur with these patients. Again, your history and your physical will be really important as well. So these patients can present with B symptoms. Itching is kind of a classic finding, or redness of the face, the palms of the hands, and splenomegaly on the physical exam. So I'm sure this looks like a very intense figure, but it's from a recent review, including all the most up-to-date studies looking at causes of erythrocytosis. As you can see, the initial test we do check most patients for JAK2 mutations, which are the most common mutations found in polycythemia vera. Even though it's rare to find them in patients that have a normal or high EPO level, it is still recommended as part of the initial workup. So once you've ruled out polycythemia vera, the EPO level as well as the history is really going to determine your next steps. So in those patients that have had a longstanding erythrocytosis or have family members with erythrocytosis, those would be the ones you would consider whether they might have an inherited cause. And I would say most of these patients would warrant referral to hematology at that point. Really, the workup after that consists of, we usually do a P50, which we can do at Norris, looking for high affinity hemoglobins, which we typically expect in the setting of a high EPO level. And then the remainder of the workup is really sending genetic panels to look for some of these mutations. So I think from my perspective, the main role in the primary care setting would be to help rule out the secondary causes that we can see in acquired erythrocytosis. So I just wanted to go through those. So again, in patients that have erythrocytosis as a physiologic response to hypoxia, they can have either what we would call an inappropriately normal or an elevated EPO level. So the most common ones we generally see, patients with COPD, congenital heart disease, both with carbon monoxide and smoking, the pathophysiology is really similar to having a high affinity hemoglobin, where the hemoglobin's not releasing oxygen to the tissues. I think one of the important ones always to ask about on your history is the use of testosterone or anabolic steroids. Even if they're getting testosterone as a supplementation, just making sure that they're receiving the appropriate dose and it's not causing erythrocytosis. And then the one that I wanted to point out, which I think is more of a recent observation, is erythrocytosis that can occur with the SGLT2 inhibitors, which is particularly relevant to the primary care setting. So in this, it was actually noted in the initial trials, I believe, of these drugs, but in a retrospective study looking at patients presenting with erythrocytosis, they found that it can happen with really any of the SGLT2 inhibitors. and really at varying times in therapy. So it doesn't always happen immediately. It can occur up to, again, you can see 5.7 years after starting the medication. They can have relatively high peak hemoglobin levels. Typically the EPO is normal or increased. And then it does resolve once the medications are stopped, but it can take a while. So you can see as up to 12 months. And again, several mechanisms have been proposed for why this occurs. They think potentially drug-induced hypoxia, changes in iron metabolism. Some studies have shown an increase in EPO production. So I would say if you have one of these patients in your clinic, the first thing I would do, if possible, would be to stop the medication and then see if the erythrocytosis resolves. If not, we can move on to working up other potential secondary causes. And then in the setting of more significantly increased EPO levels, we think of things like EPO secreting tumors. So most commonly, we would think of kidney tumors, liver tumors, uterine fibroids can be another common cause. Again, the erythrocytosis will resolve once the tumor or the fibroid is treated. And then again, renal artery stenosis, renal cysts, and post-transplant erythrocytosis is one, especially being here, we see fairly often since we're a transplant center. And it's typically after renal transplant. Okay, moving on to thrombocytopenia and thrombocytosis. So I would say if you have a patient that presents with thrombocytopenia, really the first thing you want to do is make sure the thrombocytopenia is real. So oftentimes they'll comment on platelets being clumped on the smear. The next best step, if they note clumping, is to repeat a platelet count. So the anticoagulant that's included in the CBC2, EDTA can cause platelet clumping. So we typically recommend repeating the CBC in a sodium citrate or blue top tube. If your repeat platelet count is normal, then we call this pseudothrombocytopenia. Again, it's just something to know going forward when there's platelet clumping present, just to repeat the test in a separate tube. So as far as when you should be concerned about thrombocytopenia in your clinic, so typically when the platelet count is over 100,000, even though it might be slightly below the normal range, especially if it's stable, it usually doesn't indicate significant pathology. So things that we consider being warranting further workup would be if the platelet count drops below 100,000. If we see additional CBC abnormalities, so particularly things like anemia or neutropenia, if it's a progressive thrombocytopenia, if the patient is also having bleeding manifestations, particularly because they may warrant treatment, or if they have other symptoms suggestive of an underlying disorder where we think the thrombocytopenia might just be a side effect of what's going on systemically. So again, this is our general differential for thrombocytopenia, and I think probably the easiest way to think about it when we're approaching our workup. So just starting with the more straightforward causes. So again, dilution is generally only in the setting of massive transfusion, so usually in the setting of trauma, so not something we see commonly. Sequestration, so this is something we see commonly, particularly in our patients with cirrhosis, where platelets are really getting trapped in the spleen, but it can really occur with in any person that has splenomegaly, no matter the underlying cause. So that really leaves us with determining whether the thrombocytopenia is due to decreased production or increased consumption. So some of the more common causes of decreased production you can see here. I would say the most common cause would be medications. So I did want to give you this website. So this website is on drug-induced thrombocytopenia. And when I'm evaluating these types of patients, I always go through their medication list and compare it with this website. So it gives reports of all of the cases that have been associated or thought to be associated with specific types of drugs, and also includes specifically a list where they found drug-induced antiplatelet antibodies for specific medications. So those particularly I find to be the best evidence that these medications can cause a drug-induced thrombocytopenia. So I would say that's at least something that can be done in the primary care setting. Again, infections, typically severe sepsis is when we can see isolated thrombocytopenia. Some of these other causes of decreased production we've gone over, typically because they can also present with anemia or other cytopenias. And then alcohol is another one that can cause a temporary bone marrow suppression with thrombocytopenia that should respond with cessation of alcohol. And then increased consumption, we've covered a lot of these in our discussion of anemia and the TMAs that will present with a consumptive thrombocytopenia. But some of the causes of consumption with isolated thrombocytopenia, so I think the first one we think about is ITP or immune thrombocytopenia. I think the most common workup we send in the outpatient setting is looking for secondary causes of ITP. So the 3 infections we typically test for would be HIV, hepatitis C, and then we also test for H. pylori. And in some circumstances, if we treat the underlying infection, the ITP will resolve, although not always. HIT, this is something I would say we get consulted about more in the inpatient setting. So heparin-induced thrombocytopenia. Again, this is a consumptive isolated thrombocytopenia. And really the most important thing is doing a history and finding out about heparin exposure. And then again, in the setting of pregnancy, you would want to consider something like HELP, which is a variation of a TMA. Moving on to thrombocytosis, which I would say is another frequent referral. So again, generally we see platelet counts over 450,000 as being consistent with thrombocytosis. And again, 2 categories we're trying to distinguish: primary versus secondary. In most studies, usually 80 to 90% of cases are due to secondary causes. So these primary hematologic disorders are fairly uncommon. So this was from one study looking at the distribution of various causes in both primary and secondary thrombocytosis. So in primary, the most common etiology is going to be essential thrombocytosis, followed by other primary myeloproliferative disorders or hematologic malignancies. I think more importantly for you, the most common causes of secondary thrombocytosis to rule out, you can see on the right. I would say infection, inflammation, and iron deficiency are going to be the most common ones that we see. But you can also see post-splenectomy is another typically a common inpatient consult we get, patients with bleeding, or even patients with hemolysis. From this same study, they actually looked at the difference in platelet counts between primary and secondary. Although it's not specific, it could be a good indicator of the underlying disorder. So here they consider mild thrombocytosis to be any platelet count below 700,000, which is represented by this darker gray bar. And as you can see, most cases of secondary thrombocytosis are going to present with this mild thrombocytosis. Whereas in primary, you have almost half of patients presenting with severe or extreme thrombocytosis, which is considered to be over 1 million. So again, if you have a patient presenting with extremely high platelet counts and really no obvious secondary cause, I would be suspicious for a primary disorder and definitely refer to hematology. So again, other findings on the CBC that can be helpful. With MPNs, we expect other cell lines to be elevated. You can, potentially in the primary care setting, I have had referrals where they've already sent some of the molecular workup when they've ruled out secondary causes. So for MPNs, you can send a panel that looks at the 3 most common mutations that we see. So the JAK2, CALR, and NPL. And then CML is also at the top of the differential, and so you can send the BCR-ABL PCR. But if you're sending these, again, I think it would also be a good referral to hematology at the same time. Again, with secondary, The initial workup always includes a CRP just to get a sense of underlying inflammation, as well as an iron panel. Because if iron deficiency is present, repletion of iron typically resolves the thrombocytosis. And again, as far as secondary causes, if halo-jolly bodies are noted on that slide review, that can suggest either surgical or functional asplenia. Okay, neutropenia. So again, we mainly get concerned about neutrophil counts when they start to drop below an ANC of 1.5 or 1500. We do put them into these various categories because it can be helpful in understanding what the underlying etiology is, as well as the risk of infection. So we typically only see the higher risk of infection when the ANC is below 200. So factors that you should consider when you see patients with neutropenia. So first of all being, what's their individual baseline? And we'll talk in a few slides about why that's important before going and performing a lot of potentially unnecessary tests. You want to know whether it's acute versus chronic. What is the severity? So again, we're going to be more concerned, and the workup will be more urgent for more severe neutropenia. Is it associated with recurrent infection? So typically patients that have recurrent infection, we suspect more of a congenital cause or neutropenia associated with immunodeficiency. Because just having isolated neutropenia, especially mild to moderate, doesn't significantly increase the risk of infections on its own. And then you want to know if it's isolated or is it associated with other cytopenias that might make you think of a more global bone marrow failure syndrome. So some of the most common acquired causes, so autoimmune, where we can see isolated neutropenia, or in the setting of other autoimmune diseases, I would say is a common referral. So primarily patients with lupus. We can also see it in patients who have rheumatoid arthritis. So when neutropenia accompanies rheumatoid arthritis and splenomegaly, we call that Felty syndrome. We can see it with other malignancies. So specifically, this chronic low-grade malignancy called large granular lymphocytic leukemia can prevent with neutropenia, or MDS more commonly. I think the most important one to recognize is medication-induced neutropenia, specifically agranulocytosis, because those are the patients that are going to be presenting with infections or febrile illnesses. So from this one study, it seemed that the highest odds for developing agranulocytosis occurred with these medications. So clozapine, methimazole, I'm sure everyone is familiar with, Bactrim, beta-lactam antibiotics. Again, it should resolve after discontinuation of the drug, but while they're severely neutropenic, they might need growth factors, particularly if they have infection. And then again, certain infections are more likely to present with neutropenia, and then a couple of the other causes that we've reviewed before. Congenital, again, I would say if you suspect a congenital cause, primarily because of history of infections, that definitely warrants referral either to a hematologist or an immunologist. When it's an isolated neutropenia, we think of severe congenital neutropenia. Those are going to be the ones presenting with ANCs less than 500. A more common one we might see is cyclic neutropenia. So these patients have fluctuating neutrophil counts, usually over a 21-day period. We usually catch it by doing weekly CBCs over about 6 to 8 weeks to see if we can demonstrate that pattern. Again, I mentioned neutropenia associated with immunodeficiency. And then specifically, I was just going to talk a little bit about benign ethnic neutropenia, I think is often on the differential depending on the patient. So historically, lower ANCs have been linked to African ancestry. The other thing that has been associated with lower ANCs is this Duffy null phenotype, so absence of the Duffy antigen on red blood cells. And it's due to this polymorphism in the dark gene. And it's thought to affect how neutrophils move from the bone marrow into the peripheral blood, as well as then subsequently into the tissue. So they just are, there's a decrease in circulating neutrophils. One thing that had previously been identified was that there was a higher prevalence of this Duffy null phenotype in those of African ancestry. And then recently this year, a study was published where they looked at healthy individuals identifying as Black or African American. They looked at the Duffy phenotype in these people, as well as and its association with ANC. So what they found was 24% of the Duffy null had neutropenia, whereas none of those that had the typical Duffy phenotype had neutropenia. So it seemed that really it was the Duffy null phenotype that is predicting for neutropenia as opposed to race. So I think it might eventually be called Duffy null neutropenia, something along those lines. But I mention it because it is something we can test for. So we've been sending it now, again, mainly to confirm that this is their baseline, because this is associated with just mild neutropenia, no increased risk of infection, and identification of this could potentially save other costly and time-consuming workup. So you order a DAT, and just in the comments, you can let the blood bank know that you want testing for the Duffy phenotype.
Caitlin, I'm sorry to interrupt, but it's actually 1 o'clock now.
Oh, okay.
Yeah, I don't know if you want to skip to your MOC question. And then for people who joined us a few minutes after the start of the talk, the requirement is to message Brandon. You can either do it today via email or quickly in the chat box. It needs to include your full name, your title like MD, PharmD, etc., your month and day of birth, and your medical license number, as well as the correct answer here. So Caitlin, do you want to walk us through this question, please? I'm sorry, sorry to rush you, but you know, a lot of people will have clinic at 1.
Yeah, no problem. So a 27-year-old Caucasian female is in your clinic for her yearly physical. Her past medical history is notable for rheumatoid arthritis. She was recently prescribed naproxen and prednisone by her rheumatologist, but has not yet started the medication. A CBC reveals an absolute neutrophil count of 950 cells per microliter, a platelet count of 135,000, and a hemoglobin of 10.5 with an MCV of 73. Eosinophil count is normal. The physical exam is notable for multiple swollen joints and splenomegaly. What is your likely diagnosis? Benign ethnic neutropenia, myelodysplastic syndrome, Felty syndrome, or severe congenital neutropenia? C.
Feel free, Caitlin, if you want to discuss, but I'll just reiterate to everyone in the audience, to get the MOC credit, just let Brandon know your day and month of birth, your full name, your medical license number, and your title, and then the correct answer. Sorry, go ahead.
Do you want me to discuss or just?
I'll leave it up to you. Why don't you discuss? I think it's fine.
Okay. So the answer here is C. So just going through the answer choices. So as far as benign ethnic neutropenia, so I don't think I necessarily pointed, I did mention that historically, we see this in those of African ancestry. Here they do tell you that she's Caucasian. Myelodysplastic syndrome would be unusual in someone this young, although she does have a mild pancytopenia. Felty syndrome, again, I had mentioned a few slides back, can be seen in patients with RA, and it's notable for that triad of rheumatoid arthritis, which we see in our patient, plus the neutropenia as well as splenomegaly. And again, splenomegaly we wouldn't expect to see in benign ethnic neutropenia or severe congenital neutropenia. They don't really give us a history of having infections or a long-standing history of neutropenia. I guess they tell you that she comes in for a yearly physical, so theoretically you should have picked up a neutropenia prior to this if it was congenital. So I think those are some of the important points from the question. Okay. Let's see. I mean, do most people have to go to clinic? I don't have that many more slides, but.
Yeah, I think just keep rolling ahead. I
Okay.
apologize. I may have to log off early because I have to give a talk myself, but feel free to
I'll wrap it up
keep
in
talking, and anyone
Okay.
who is available will stay on. Thank you.
Okay. So moving on to eosinophilia. So again, for most of these, we're really trying to differentiate between whether this is a primary heme disorder or reactive cause. So the most common reactive causes we see, I would say, are infections. So especially parasitic infections and otherwise asymptomatic people. So typically we'll test with at least a strongyloides antibody, and if it's positive, treat empirically and see if the eosinophilia resolves. Fungal infections are another common one to cause eosinophilia. Allergies and hypersensitivity diseases, which you should be able to identify based on the patient's history or potentially physical exam. Connective tissue diseases, and then a big one is medications. And particularly wanting to rule out DRESS if they're also presenting with other systemic symptoms, liver test abnormalities, rash, those types of things. Primary, so this is really, once you've ruled out these reactive causes, this would be when you refer to hematology, so we can evaluate for these primary causes. Again, we've kind of gone over some of the HNP findings that might point you toward myeloproliferative diseases. For lymphomas, they can present with eosinophilia, so again, you might note lymphadenopathy or splenomegaly on your exam, as well as the presence of B symptoms. And particularly with T-cell lymphomas that present with eosinophilia, they might also present with skin rash. And then the last one that I wanted to go over is lymphocytosis. So again, the reactive causes that are most common would be particularly viral infections, and as I showed you before, potentially some of those atypical lymphocytes on the white cell differential. Smoking is definitely a common cause, and again, it's not going to go away unless they stop smoking. Lymphocytosis as a response to stress, or even in the setting of post-vaccination, which again should be temporary. Some of the primary causes, so one thing that is, or lymphoproliferative disorders really are the group of hematologic diseases that are easily assessed by flow cytometry. So flow cytometry looks at the proteins expressed by cells, and oftentimes with lymphoproliferative disorders, the diagnosis can be made on flow cytometry, which is not the same as with some of the other disorders we've talked about, like myeloproliferative disorders, for example. So this is something that can easily be ordered in the primary care clinic. It's reviewed by the hematopathologist, and if they note that there's a clonal process going on, again, they'll alert you and you can immediately refer to hematology. I think one of the more common ones you might be presented with are patients who come in with CLL. So these are going to be older patients. It's a chronic disease. They might only present with lymphocytosis. But they can have other associated cytopenias, which are typically due to immune related etiology. So ITP, warm autoimmune hemolytic anemia, and then less commonly, but we do have a few, pure red cell aplasia. Lymphomas generally are not going to be something you necessarily pick up on a CBC, although a few low-grade lymphomas can present with circulating lymphoma cells, which again, you can evaluate with flow cytometry. And then large granular lymphocytic leukemia I mentioned before, you might see in a patient presenting with isolated neutropenia. So again, if you feel like you've ruled out all of the reactive causes, particularly for lymphocytosis, I would recommend sending flow cytometry and referring to hematology. Okay, the last thing I just wanted to mention, so again, might seem outside of the scope of primary care practice, but I think eventually will become more integrated, hopefully as we learn more about this set of disorders. So clonal hematopoiesis, is really defined by acquisition of a mutation in a hematopoietic stem cell. And that mutation gives that cell some sort of growth advantage so that it it becomes overrepresentative in the blood cell population. So a proportion of those cells circulating in the blood are really only coming from one single clone. So we know that it increases with age and that it can be present in otherwise normal, healthy individuals. So what is interesting, not only does it seem to increase the risk for hematologic disorders, but now it seems that it also can increase the risk and severity of other chronic diseases that you are taking care of in the primary care setting. So this study by Jaiwal and colleagues really is what initiated the immense interest in this area, not only within hematology, but other areas of medicine. So they performed DNA sequencing on samples from patients who participated in large studies like the Jackson Heart Study and the Women's Health Study. And they specifically sequenced genes that are typically implicated in myeloid malignancy. So maybe some of the common ones you've heard of would be TET2, DNMT3A. So what they found was the prevalence increases with age. So people 90 years and older, about 20% had at least one of these mutations, but didn't necessarily have any CBC abnormalities or a history of hematologic cancer. They did see that it increased, the relative risk for hematologic cancer was increased, although the absolute risk was still low. But what was interesting from the study and somewhat unexpected was that patients with these mutations had an increased risk for incident heart disease as well as stroke. So since then, multiple studies have been performed looking at the association of CHIP, which is what this entity is called, so clonal hematopoiesis of indeterminate potential, looking at the association of CHIP with other chronic diseases. So some of the basic research has suggested the connection seems to be these mutations increase inflammation, so specifically within the monocytes that carry these mutations. So it's found to be associated with diabetes, certain autoimmune diseases, and even progression of solid tumors in patients with cancer. When it is associated with low blood cell counts or cytopenias, we have another name for it, so clonal cytopenia of undetermined significance. Again, I'm not expecting this to be something that you diagnose or to send off this testing. It's usually something we do when we've ruled out other causes. But again, I think the important point is that we're finding that these mutations are affecting risk for these other chronic medical problems. So currently, there's really no specific management recommendations. We don't know how to intervene or that intervening really in any specific way affects this risk, but that's the focus of ongoing research at this point that hopefully eventually will make it into the primary care setting. So lastly, along those lines is another form of clonal hematopoiesis that you could potentially pick up in the primary care setting. So it's monoclonal B-cell lymphocytosis. I would think of this similarly to an MGUS or monoclonal gammopathy of undetermined significance. So a premalignant condition often picked up incidentally in the primary care setting that does somewhat increase the risk for progression to a heme malignancy. So again, it's identified by performing flow cytometry and identifying this clonal population of cells. We say that it's a clonal population that's less than 5 × 10⁹ per liter. If it's more than that, we would diagnose them with CLL. And typically the phenotype is similar to what is seen in CLL. Just like MGUS, as well as what I just showed you in the setting of CHIP, the prevalence increases with age. So patients over 70, about 20% will have evidence of a clonal B-cell population. And again, similar to MGUS, where there's a 1% per year risk of progression of myeloma, in this setting, there's a risk of transformation to CLL. And again, that risk is about 1 to 4% per year. Some of the risk factors they've found that are associated with developing this monoclonal process. So family history of malignancy, specifically heme malignancy. It's more common in males and in those that have a history of infection, particularly they noted Hep C, and in those with other types of immunodeficiency. Okay, so, and sorry, we went over time, but just to summarize, so Again, I think understanding how to use the CBC, there can be a lot of information contained there, can definitely help making your initial workup of these CBC abnormalities more efficient before referring to hematology. Again, I just wanted to stress the importance of the reticulocyte count, especially when you're undergoing workup of anemia. I would say that the majority of these abnormalities are going to be secondary or due to other underlying disease conditions, which hopefully can be evaluated in the primary care setting. But hopefully we went through some of the other CBC abnormalities and quote unquote red flag signs and symptoms that would prompt you to refer to a hematologist early for evaluation. Those are my references. There's the question again if you need to see it. And I know we've run over, but if anyone has any questions, I'm happy to answer them. Okay.
Thank you very much, Dr. O'Neill. I think we had do we have any questions from faculty? Then we have no questions.
Okay, well, I appreciate everyone's attention. Thank you.
Thank you very much.
Thanks, Brandon.
Yes, ma'am.